Hello everyone and welcome to our module on AV and bundle branch blocks. Let's begin by reviewing the path of electrical impulse conduction through the heart. So by way of review, electrical impulses under normal conditions are generated in the SA node. Electrical depolarization then spreads to both of the atria. However, there is only one path by which electrical impulses can reach the ventricle, and that's by funneling through the AV node and then the His bundle. After the His bundle, electrical impulses reach the left and right bundle branches, and from there they go to the Purkinje fibers, and that leads to ventricular depolarization. So it's very important that you understand how all this electrical activity is represented on the surface EKG. In the module on action potentials, I talked about how the P wave represents atrial depolarization, and I also talked about how the QRS complex represents ventricular depolarization. In this module, what I'm going to focus on is what happens between these two phenomena. So the reason for this flat portion on the EKG is that electrical activity must pass through the AV node, the His bundle, the bundle branches, and the Purkinje fibers before the ventricles can depolarize. In other words, the reason that the QRS does not immediately follow the P wave is because it takes time to go through all of these structures. And it's very important that you understand that in order to understand AV blocks and bundle branch blocks. So AV blocks are conditions in which there is slowed or blocked conduction between the atria and the ventricles. That's why they're called AV blocks. And this can result in two potential abnormalities on the surface EKG. The first thing an AV block can do is cause a prolonged PR interval. That's what I've shown in this tracing at the bottom left side of the screen. A normal PR interval is 200 milliseconds or one big box wide. You can see that the PR interval on this EKG is almost two big boxes wide, so it's very prolonged. So when there is delayed conduction between the atria and the ventricle through any of those structures I mentioned on the last slide, that can lead to a prolonged PR interval. Now, if the block is severe, then it can lead to a lack of conduction between the atria and the ventricles, and on the surface EKG, that will be represented by a non-conducted P wave. So if you look at this tracing here, we have a P wave followed by a QRS complex. So this P wave is conducted to the ventricles. That's why it generates a QRS complex. This P wave here is not conducted to the ventricles, and it does not generate a QRS complex. That's called a non-conducted P wave, and that's what can happen if you have a severe type of AV block in which the electrical impulses cannot reach the ventricles. In terms of symptoms, AV blocks are often incidentally noted when an EKG is performed for some other reason. This is especially true in milder forms of AV block when there are very few or no non-conducted P waves. AV blocks can, however, progress and cause bradycardia. This is especially true when many or all of the P waves are not conducted. This can result in bradycardia, and we'll talk about how that occurs in a few slides. But if a patient does develop a significant bradycardia and slow heart rate, this leads to a low cardiac output, and that leads to symptoms of fatigue, dizziness, and sometimes even fainting or syncope. And when AV blocks are symptomatic and result in a very slow heart rate, that's when they're often treated with a pacemaker, which we will also talk about later. It is a device which is implanted to pace the heart and prevent the bradycardia from occurring. It's very important that you understand the anatomy of AV blocks. In other words, you need to understand which anatomical structures are diseased in the various different forms of AV blocks. So the first thing for you to know is that an AV block can be caused by disease in any portion of the AV conduction system. In other words, any portion of the heart that conducts electricity from the atria to the ventricle. So this could involve the AV node, or the His bundle, or the bundle branches, or the Purkinje fibers. However, clinically, we divide the causes of AV blocks into two categories. The first category are those forms of AV block that are caused by AV node disease, and the second category are AV blocks caused by disease in the so-called His-Purkinje system, meaning anywhere from the His bundle through the bundle branches to the Purkinje fibers. The reason we divide AV blocks up in this manner is because AV node disease is usually less dangerous than His-Purkinje system disease. Usually, AV node disease results in fewer drop beats and less bradycardia, and importantly, AV node disease often improves with exertion. When you exert yourself, you increase your sympathetic nervous system activity, and as you may know, the sympathetic nervous system can speed conduction through the AV node. Therefore, it often resolves AV blocks which are caused by AV node disease. His-Purkinje disease, on the other hand, is more dangerous. It usually does not improve with exertion, and it often progresses to complete heart block where none of the atrial impulses are being conducted to the ventricles, and His-Purkinje disease often requires a pacemaker for therapy. So now that we understand those principles of AV blocks, let's talk about the four types of AV blocks in terms of how they appear on the surface EKG. A type 1 AV block involves only prolongation of the PR interval. All P waves are conducted, there are no drop beats. Type 2 AV blocks involve some conducted P waves and some that are not conducted, and it's split up into two subtypes called Mobitz type 1 and Mobitz type 2. And then finally, a type 3 AV block is where there is no impulse conduction from the atria to the ventricles. So we'll go through these one at a time, and we'll start with first-degree AV block. First-degree AV block involves only a prolonged PR interval. All of the P waves are conducted to the ventricles. So if we look at this EKG tracing, this P wave begins right on this solid line right here. The QRS complex does not start until almost 2 big boxes later. A PR interval should be under 200 milliseconds, which means it should be under 1 big box in size. This PR interval is too long, and that is the hallmark of first-degree AV block. Notice that all of the P waves are followed by a QRS, meaning they are all conducted. If any of these P waves did not result in a QRS, then we would not be looking at first-degree AV block. We'd be looking at some other type of AV block. The block in first degree is usually in the AV node. For that reason, it has a favorable prognosis for all the reasons I mentioned before. And you should be aware that first-degree AV block is commonly caused by circumstances in which conduction through the AV node may be slowed. So, for example, patients on beta blockers often have a first-degree AV block. Patients taking calcium channel blockers often have a first-degree AV block. Well-trained athletes also often have a first-degree AV block. Well-trained athletes, when they are at rest, have very high parasympathetic nervous system tone. This slows the heart rate, but it also slows conduction through the AV node, and it can result in a first-degree AV block. There are obviously no symptoms from this condition because all of the P waves are conducted, so there's no opportunity for bradycardia to develop, and therefore first-degree AV block is something that's usually picked up incidentally when an ECG is performed for any reason. Now let's talk about second-degree AV blocks, and as I told you before, in all second-degree AV blocks there are some conducted P waves and some non-conducted P waves. I also told you before that second-degree AV blocks are subdivided into two subtypes, and we'll talk about the first subtype now, which is called Mobitz type 1 block or Wenke block. In Mobitz type 1 or Wenke block, the anatomic location of the block is also usually in the AV node, just like first-degree AV block. You can think of Wenke block as a first-degree AV block that gets worse with each heartbeat until such time as there is a non-conductive P wave. The hallmark of Wenke block is progressive PR prolongation followed by a drop beat. Let's take a look at this tracing on the screen. We have a P wave followed by a slightly prolonged PR interval. We then have another P wave followed by a longer PR interval. We then have a P wave which is not followed by a QRS. It results in a drop beat. It's a non-conductive P wave, and this is the hallmark of Wenke block. It's like first-degree AV block with the PR prolongation, but it gets worse with each P wave until such time as you have a non-conducted P wave. If you have trouble identifying the progressive PR prolongation, I'll give you a trick. Focus on the non-conducted P wave, then look at the PR interval just before the non-conducted P wave and just after. Those two PR intervals will have the greatest discrepancy in length, and thus they are the easiest to see with your eye. Notice that the one before is quite long, and the one after is relatively short. Since the difference between these two is so big, it's usually the easiest for you to pick up. I've cleared the screen so I can show you another important feature of Wenke block, and that is known as grouped beating. Notice that we have two QRS complexes relatively close together, followed by a space because of the drop beat. We then have two QRS complexes which are relatively close together. This is known as grouped beating, and this is a hallmark of Wenke block. And as we will see later, this is a very important way for distinguishing Wenke block from complete heart block. I've cleared the screen again so I can show you that the result of group beating is that the RR intervals are not regular. The RR interval is the distance between the QRS complex, and they are not regular in patients who have Mobitz type 1 or Wenke block. Notice that the RR interval here is relatively short, and then it is relatively long, and then it is relatively short again. The RR intervals are varying, and once again we will see later that this is very important for distinguishing Mobitz type 1 or Wenke block from complete heart block. As to the causes of Wenke block, they are similar to the causes of first-degree AV block. This is also a problem in the AV node in most cases, just like first-degree AV block, so anything that slows conduction in the AV node and prolongs the PR interval can lead to Mobitz type 1 or Wenke block, just like it can lead to first-degree AV block. So Mobitz type 1 or Wenke block can be seen in patients on beta blockers or calcium channel blockers or in well-trained athletes. It is generally an asymptomatic condition, and that's because it involves the AV node, and conduction through the AV node improves with exertion, so usually this block goes away when patients exert themselves. It's often identified routinely on an EKG or by an irregular pulse. The pulse will be irregular in patients who have Wenke block. It is regularly irregular, not irregularly irregular, as is seen in atrial fibrillation. So it's often the irregular pulse or a routine EKG that leads to the diagnosis of Wenke block, and there are generally no symptoms. Here's another example just to make it more clear. We have a relatively normal PR interval here, followed by a prolonged PR interval, followed by a P wave, which does not result in the generation of a QRS. Notice that we have group beating with two QRSs close together, followed by a space, followed by two close together, followed by a space and two close together. These RR intervals are varying. We have a short one, then a long one, then a short one, and these are all classic characteristics of Mobitz type 1 or Wenckebach block in the AV node. Now let's talk about the other type of second-degree AV block. That's called Mobitz type 2. Just like all forms of second-degree AV block, there are some conducted P waves and some non-conducted P waves. However, in contrast to Mobitz 1, in Mobitz 2 there is no progressive prolongation of the PR interval. Let's take a look at this example at the top of the screen. We have a P wave here with a normal PR interval, and you can see normal PR intervals in Mobitz type 2. Sometimes they are prolonged, sometimes they are normal. We then have another conducted P wave with the same PR interval. In other words, there is no prolongation. We then have two non-conducted P waves in a row. Then conduction resumes, and we have the same PR interval that we had before the drop beats. So once again, in contrast to Mobitz type 1, there is no progressive prolongation in Mobitz type 2 like you see in Mobitz type 1. The reason this disorder is different than Mobitz type 1 is because the block is usually in the His-Purkinje system, not the AV node. What's happening here on an anatomical level is that the His-Purkinje system is hanging on by a thread. It's able to conduct the electricity for these two beats here, and then it is unable to conduct for the next two, and then conduction resumes. As I told you before, His-Purkinje system disease is much more dangerous than AV nodal disease, and that's true in Mobitz type 2. The His-Purkinje system is barely functioning here. It's conducting some beats but not others, and thus there is a high risk of progression to complete heart block, and there often are symptoms from numerous drop beats in a row, as shown in this example at the top of the screen. Another feature of Mobitz type 2 is that it's often seen together with a bundle branch block. Remember, this is caused by disease in the His-Purkinje system, which includes the bundle branches. So often you see the AV block of Mobitz type 2 along with a right or left bundle branch block. And we'll talk later about right and left bundle branch blocks, but for our purposes here, if you have one of the bundle branches blocked, you will get a prolonged QRS interval, and you see that in this tracing at the top of the screen. QRS interval is prolonged, and that is often seen together with Mobitz type 2 because the source of the disease in Mobitz type 2 is usually in the His-Purkinje system, which is where the bundle branches lie. I've shown another example at the bottom of the screen. We have a PR interval here that's prolonged, followed by a drop beat. We then have several conducted P waves with the same PR interval. There's no varying in the length of the PR interval. This is all consistent with Mobitz type 2 AV block. Notice also that the QRS complex in this bottom example is also prolonged, consistent with a bundle branch block, which is often seen together with Mobitz type 2. And as I told you earlier, His-Purkinje system disease is more serious. It's often symptomatic. Dropped QRS complexes often lead to a low cardiac output and dizziness and syncope. Many of these patients will progress to complete heart block if they're not treated with a pacemaker. Now let's talk about the final form of AV block, and that's called third-degree AV block. In this form of AV block, there is no conduction of electrical impulses from the atria to the ventricle. This is an example of third-degree AV block shown on the screen. You can see that there are P waves because the sinus node is depolarizing the atria. However, none of those electrical impulses are being conducted to the ventricles. Some lower pacemaker within the His-Purkinje system or in the ventricular myocytes itself is depolarizing the ventricles at a slower rate. The hardest part about recognizing third-degree AV block, especially as a medical student, is distinguishing it from Mobitz type 1 or Wenckebach. You will be inclined to think that this P wave might be conducted to generate this QRS complex, and that this one is conducted with a longer PR interval to generate this QRS complex. Because those PR intervals appear to be varying, you'll then think that maybe this is Mobitz type 1. However, notice that the RR intervals are completely regular here, and that is the key to recognizing third-degree AV block. You should never see regular RR intervals in Mobitz type 1 or Wenckebach. When you see regular RR intervals with varying PR intervals, you must understand that that means that those P waves are not being conducted and that you have separate and dissociated depolarization of the atria from the ventricles. This is usually a form of heart block caused by His-Purkinje system disease. It's usually symptomatic. Patients with this usually have a bradycardic escape rhythm, meaning a slow heartbeat. They will have symptoms of low cardiac output like dizziness, fatigue, and syncope, and this usually requires treatment with a pacemaker. Here's another example. This time we have a narrow QRS complex. Once again, notice that these RR intervals are completely normal. That is how you can recognize this as complete heart block. Don't be confused and think that maybe this is a prolonged PR interval followed by a non-conducted P wave followed by a short PR interval and that this is Wenckebach. This cannot be Wenckebach because you do not have group beating and you have normal RR intervals. There's an important tie-in between cardiology and infectious disease that has to do with AV blocks, and that involves Lyme disease. Lyme disease is named for Lyme, Connecticut, where it was initially described. It is an infection by a spirochete called Borrelia burgdorferi, and I talk about this in more detail in the spirochete module in the infectious disease section. In stage 1 of Lyme disease, patients develop a bullseye rash, as I've shown on the screen here. However, in stage 2, they can develop what's known as Lyme carditis, and Lyme carditis presents with varying degrees of AV block. You can see first, second, or third degree AV block in patients who have Lyme carditis, and the AV block will improve with antibiotics, so it's important to make the diagnosis that the AV disease is caused by Lyme disease. There is some important vocabulary you need to understand around AV blocks. When we say that a patient has complete heart block, we mean that impulses cannot be transmitted from the atria to the ventricles. This is what we saw in the examples of third-degree heart block a few slides ago. When we say there is AV dissociation, we mean the atria and the ventricular depolarization have become uncoupled or dissociated from one another. This can be caused by complete heart block, as we saw in those examples of third-degree heart block. However, it can also occur if the ventricular rate gets higher than the sinus rate in absence of heart block, and this is seen in ventricular tachycardia and some other tachycardias. This EKG is an example of ventricular tachycardia. This arrhythmia is caused by rapid depolarization of the ventricles by some electrical foci within the ventricles itself, in other words, outside of the normal sinus node and conduction system. This results in a very fast heart rate and wide QRS complexes, as I've shown on the screen. But you will notice, if you look very carefully, that there are little bumps seen within these wide QRS complexes. I've circled one with my pen. Those bumps are P waves coming from sinus node depolarization. In ventricular tachycardia, there is AV dissociation, but it occurs in absence of complete heart block. I've zoomed in here so I can show you more clearly some of the P waves being generated by the sinus node depolarization. The sinus node is depolarizing the atria, and the ventricles are being depolarized by the aberrant focus of electrical activity. This is what occurs in ventricular tachycardia, and in fact, AV dissociation is one of the hallmarks of ventricular tachycardia, and I just want you to appreciate that it occurs in absence of blocked conduction between the atria and the ventricles. Another important term for you to be familiar with is the term escape rhythm. Recall that the SA node is normally the dominant and fastest pacemaker in the heart. It normally controls depolarization of all the cardiac structures. However, in heart block, the SA node cannot send impulses to the ventricles. Luckily, lower pacemakers exist, however, they are slower, so the SA node under normal resting conditions can fire at a rate of 60 to 100 beats per minute. The AV node can also depolarize the ventricles, but only at a rate of 40 to 60 beats per minute. The His bundle, the bundle branches, and the Purkinje fibers can also depolarize the ventricles, however, they can only do this at a rate of 25 to 40 beats per minute. So if one of these lower pacemakers takes over because the SA node is not working because of AV block, this will result in depolarization from a lower pacemaker but at a much slower rate. So when there is heart block, a lower pacemaker depolarizes the ventricles, and we call this generation of an escape rhythm by a lower pacemaker. And the rate of that lower pacemaker is going to determine the symptoms for the patient. If the lower pacemaker is very slow, there will be a low cardiac output, and this will cause dizziness and syncope and hypotension. On the other hand, if that lower pacemaker is less slow, then the patient may only have symptoms of fatigue or exercise intolerance. These symptoms occur because those lower pacemakers cannot increase their rate the same way the sinus node does with exertion, and thus when the patient tries to exert him or herself, they develop fatigue and exercise intolerance. Shown on the screen are the 4 types of AV block and the common anatomical site of the block. It's very important for you to remember this. First degree and Mobitz type 1 are usually caused by problems in the AV node. Mobitz type 2 and complete heart block or third-degree heart block are usually caused by His-Purkinje system disease. Now, these sites I've shown on the screen are not 100%. You can find examples in the literature of exceptions to these rules, but what I've shown you on the screen are the most common locations of the block in patients with the 4 types of AV block. So what are some of the causes of heart block? In other words, what causes the impairment of impulse propagation from the atria to the ventricle? And some of these causes we've already discussed. So drugs can slow conduction from the atria to the ventricles, especially in the AV node. We talked before about how beta blockers and calcium channel blockers can slow AV node conduction, so can digoxin, and all of these drugs can cause AV block, especially the forms that are caused by slow conduction through the AV node. We also talked before about how high vagal tone can slow conduction through the AV node. This occurs in athletes, and this can lead to AV block, especially the types that involve the AV node, like Mobitz type 1 and first-degree AV block. And then one thing we haven't talked about, which is a common cause of the more advanced forms of heart block, is fibrosis and sclerosis of the conduction system. This occurs to some degree with aging, and this is the reason that a lot of older patients, especially people in their 70s or 80s or 90s, will develop advanced types of AV block, especially Mobitz type 2 and complete heart block, and they will need to have a pacemaker because there is no treatment other than a pacemaker for the fibrosis and sclerosis that impairs conduction between the atria and the ventricles. So let's talk about pacemakers. This is the treatment for high-grade AV block, which usually means third-degree AV block or Mobitz type 2, especially when it occurs in patients who have symptoms like syncope or dizziness. A pacemaker is a small machine with a battery that can last 5 to 7 years. This is a picture of one on the right side of the screen. It fits in the palm of your hand. It's implanted below the skin, usually on the left side of the chest, with wires that travel through the subclavian veins to the heart. This is a chest x-ray of someone who has a pacemaker. You can see the device in the upper left chest, and you can see the wires going to the right atrium and the right ventricle, and they will pace the atria and the ventricle as needed so that the patient does not develop symptoms of bradycardia. Now let's talk about bundle branch blocks. So when both bundle branches are blocked, this results in AV block. This is a form of His-Purkinje system disease. Remember, the His-Purkinje system includes the bundle branches. So if both bundle branches are sick and do not conduct impulses, then that leads to AV block. If one bundle branch only is blocked, however, either the right or the left, this does not cause AV block. Instead, it will cause the QRS to be prolonged in the setting of a normal PR interval. To understand this, let's imagine that the SA node depolarizes in the heart of a patient who has a right or left bundle branch block. In other words, a patient where only one bundle branch is blocked. What will happen is that the atria will depolarize, creating a P wave, and then electrical activity will move through the AV node and the His bundle. When it reaches the bundle branches, one of the bundle branches is blocked, but the other one is not. This means that the QRS complex will begin on time. In other words, there will be a normal PR interval because the QRS complex starts when it should. However, it will take longer to depolarize the ventricles because one of the bundle branches is blocked. This will result in a prolonged QRS complex in the setting of a normal PR interval. Shown on the screen are examples of a right and left bundle branch block. First, let's look at the EKG strip at the top of a normal QRS complex. This is a person who does not have either bundle branch block. This QRS is very narrow. It's less than 3 boxes wide. It's less than 120 milliseconds. The only way to get a narrow normal QRS like this is to use both bundle branches to depolarize the ventricles. They are the fastest pathway for electricity to travel and depolarize the ventricles, and when you use both bundle branches normally, you get a narrow QRS. When you don't use one of the bundle branches, it creates a wide QRS. And in the right bundle branch block example and the left bundle branch block example, hopefully you can see that the QRS complexes are prolonged. Let's focus on the right bundle branch first. Notice that the QRS starts here and it ends about here. It is more than 120 milliseconds long. It is prolonged, and that's because the right bundle branch is blocked. What's happening in a right bundle branch block is that you have the two ventricles, the left and the right. Impulses can travel normally to the left and depolarize those left ventricular myocytes. However, when they try to move down the right bundle, they are blocked because the conduction system is sick. What this means is that myocytes in the left ventricle will depolarize normally, and they will slowly send electricity over to the right ventricle to depolarize the right ventricle. The result is that the QRS complex will be prolonged because it takes longer for electrical activity to work its way from the left ventricle over to the right. In a left bundle branch block shown at the bottom right side of the screen, the QRS is also prolonged. However, in this example, notice that the QRS complex in lead V1 is pointing down. If we look back at the right bundle branch block example, the QRS complex in V1 was pointing up, and that's how you can tell right bundles from left bundles. You can look at lead V1. If it's pointing up, that is a right bundle branch block. If it's pointing down, that is what is seen in a left bundle branch block. What's happening in a left bundle branch block is that once again we have the two ventricles, the left and the right. In a left bundle branch block, electricity conducts normally to the right ventricle. However, when it tries to go to the left, it is blocked. What will then happen is that myocytes in the right ventricle will depolarize normally, and they will slowly send electrical activity over to the left side of the heart. Because the electrical activity in a left bundle branch block goes in this direction, and in a right bundle branch block it goes in that direction, it creates different voltage appearances in lead V1 on the surface EKG, and that's why you can use lead V1 to tell left from right bundle branches. Here's the entire 12-lead ECG from a patient with a right bundle branch block. I've been focusing on lead V1 because that's where it's often most obvious that the QRS interval is prolonged. That's also the lead that you can use to distinguish right bundle branch blocks from left bundle branch blocks, as we described before. You'll notice that in some of these leads, the QRS complex can almost appear normal. For example, look at lead 2 here. And that's a good reminder that you need to look at all of the leads when you're trying to assess the EKG, not just a single lead. In addition, I want to point out that there are many secondary changes that occur on the ECG in patients with right bundle branch block and left bundle branch block. I have not detailed all of these because they're hard to remember and I don't recommend you focus on them, but just by way of example, you can see that the T wave is flipped in lead V1. That is common in patients with a right bundle branch block. You can also sometimes see it in lead V2. It is a normal part of the right bundle and does not represent ischemia or any other cause of a T wave inversion. And here's the entire 12 lead of a patient with a left bundle branch block. Notice that once again in lead V1, it's very obvious that the QRS complex is wide. You can also use V1 to notice that it's pointing downward, so therefore this is consistent with a left bundle branch block and not a right bundle branch block. There are also many secondary changes on the EKG that are a normal part of a left bundle branch block. You often see ST elevation, as is seen right here in lead V2. You can see T wave inversions in V5 and V6. You can look up these changes if you wish. I don't recommend focusing on them at a medical student level. Just focus on identifying the fact that in lead V1, the QRS complex is prolonged and that it's pointing downward, and therefore that is consistent with a left bundle branch block. And then finally, here's a slide showing the characteristics of a right bundle branch block in leads V1 and V6 on the left side of the screen compared with a left bundle branch block in leads V1 and V6 on the right side of the screen. I've always found V1 to be the most helpful in telling the two apart. That's the lead that I recommend you use at the medical student level. You can see that in the right bundle branch block in lead V1, it's pointing mostly up and it's pointing mostly down in the left bundle branch block example. Also notice that V1 in a right bundle branch block often has two R waves as shown in this picture. It's sometimes called an RSR prime complex. The two R waves are sometimes described as rabbit ears because they are double upward spikes like you might see on the head of a rabbit, and that is a common finding in patients who have a right bundle branch block. Bundle branch blocks in and of themselves do not cause any symptoms. They are noticed incidentally on the ECG. As we'll talk about in a minute, there may be an underlying structural heart problem that causes the right bundle branch block, and that problem may cause symptoms, but just the bundle branch by itself should not cause any symptoms. It may progress to AV block with time and the need for a pacemaker. Remember, if you've got one bundle branch blocked, that means that if the other one becomes blocked, then you're going to have his Purkinje system disease and you're going to need a pacemaker. And probably the biggest problem related to bundle branch blocks is a problem for the doctors more than the patient. And that's because the bundle branch block interferes with detection of ischemia. As we saw on those examples of right and left bundle branch blocks, there can be ST elevations and T wave inversions, which are all a normal part of the right or left bundle branch block and not a sign of ischemia. Bundle branch blocks are often caused by slowly progressive fibrosis and sclerosis, just like we talked about earlier, leading to his Purkinje system disease and causing AV blocks. And for this reason, bundle branch blocks are more common in older patients. In fact, some patients will have an EKG done for some reason when they're younger, and then when they get older, they have an EKG done, and they have developed a left or right bundle over the course of their life, and that's because their conduction system is slowly developing fibrosis as they age. What we worry about whenever we pick one of these up incidentally on an EKG is that it can sometimes represent underlying structural heart disease. So for example, you can develop a left bundle branch block if there is any disease process that has damaged the left ventricle, such as a silent myocardial infarction or some type of cardiomyopathy. And if one of these underlying processes is harming the left ventricle, it can lead to the development of a bundle branch block. In addition, you can get a right bundle branch block if you have some pathologic process leading to right heart failure. So for example, patients with pulmonary hypertension who have dilated right hearts can develop a right bundle branch block as part of the damage that is occurring to the underlying right ventricle. And that concludes our module on AV and bundle branch blocks.